Hello, everyone. Welcome to this webinar organized by Olea Medical. The topic of the day is brain perfusion imaging, pearls and pitfalls. Before I go further, I would like to review the functionality of the Cisco WebEx. Your active participation is important during the session. Right now, I have everyone on mute to avoid background noises. Throughout the presentation, I will be managing the chat functionality, and you can ask your questions in the chat section. They will be answered during the questions and answers part. Now, I'm very pleased to welcome you all and introduce Professor Dr. Max Wintermark. Max Wintermark received his training in diagnostic radiology at the University of Lausanne in Switzerland, a country that's very dear to my heart, followed by a fellowship in diagnostic neuroradiology at the University of California, San Francisco. He also holds a degree in biomedical engineering from the Swiss Federal Institute of Technology, a master in clinical research from the University of San Francisco, and an MBA from the University of Massachusetts, Isenberg School of Management, Business Administration. He worked as a faculty at the University of California, San Francisco, at the University of Virginia, and is currently a professor of radiology and the chief of neuroradiology at the Stanford University, and the leader of the Imaging Core Lab for the NIH-funded Vasculopathy in Pediatric Stroke study. He is a neuroradiologist with a specific interest and expertise in stroke, traumatic brain injury, epilepsy, movement disorders, and psychiatric disorders. Max Wintermark authored and co-authored over 500 scientific papers, book chapters, and he is the chair of the research committee of the American Society of Neuroradiology and of the imaging working group of the NINDS-funded Stroke Trial Clinical Network. Enjoy the webinar. I will answer your question at the end. Professor Dr. Wintermark, whenever you're ready, it's your time to talk.
All right. Thank you, Frank, for the very nice introduction. And thank you, Olea, for having me on this webinar today. It's really a pleasure to be here. Again, I apologize. My video was working at the beginning and now it's not working. Hopefully during the question part, I can find a way to turn it back on. But right now I don't want to touch anything because otherwise, those technical things may not work exactly as we want. So today what I wanted to do was to talk about perfusion imaging. That's something that is now being used very much because of the recent clinical trial that showed that perfusion is an important tool to select patients for mechanical thrombectomy in an extended time window. So it's something, again, that is being used routinely at multiple institutions. The particular aspect that I wanted to touch on today is that we are all using today automated software tools, such as the one that Olea offers. And that definitely represents a huge improvement. I remember when I started doing perfusion imaging, I used to process all the cases myself. And then we tried to convince the residents to do it, and that worked with a various amount of success. Then sometimes 3D labs got involved, but it was always complicated, especially when you want to provide the results in a timely manner. So definitely automated software have really made a huge difference and have had a very positive impact, again, on patient management. But the slight downside of an automated software is you sometimes don't know exactly what's under the hood. Sometimes it may be some kind of a black box. You get some maps out of this automated software. And while the software works great in the large majority of the cases, there are some instances where something happens with the patient moves, or something happens with the injection of contrast. And as a result, in those situations, the automated software may not work exactly as expected. And then it's important to recognize those pitfalls, because then it allows the radiologist to troubleshoot basically and to take the appropriate step to still get the information that is needed for optimal patient care. So what I wanted to remind you is that typically all of those software, including the Olea software, calculate different parameters. They calculate something that has to do with the cerebral blood volume. They calculate some kind of time parameter, the Tmax or the mean transit time, and they calculate also the cerebral blood flow. And they calculate basically those parameters based on several inputs. And typically, as you can see, there is an arterial input function and a venous output function that are used for the calculation of those parameters. And what I want to do with you today is I want to show you a little bit how those inputs are used to calculate the final maps, because that will allow you, when there are problems with the AIF or the VOF, to troubleshoot and to try to fix problems. So typically, and as a simplification, the artery is used to calculate the temporal information. The vein is used to calculate the cerebral blood volume. And basically after that, by combining the time information, the temporal information, and the cerebral blood volume, the cerebral blood flow can be calculated. So let's go step by step. Let's focus a little bit on the selection of the vein. And here what I wanted to show you is really what the software does when you give it a venous output function, or when he's looking for a venous output function. Basically, what the software does is it's looking for a voxel or a couple of voxel in the image that only contain blood and nothing but blood. And basically, it's illustrated in that blue voxel that I've drawn in the suprasagittal sinus. When the software finds that voxels that contains only blood, basically it's going to assign a CBV, a cerebral blood volume value of 100% of blood to that particular voxel. So 100%, it's nothing but 100 cc per 100 cc. Or if you assume that the density of the brain tissue is 1, it's 100 cc per 100 gram. And then basically what the software is going to do is it's going to compare all the other voxels. And I drew an example one, a green one as an example. And of course, in those other voxels, not the whole voxel is occupied exclusively by blood. You have some blood, you have some capillaries, but you'll have also some axons, you'll have some neurons. And as a result, the fraction of that voxel that is occupied by blood is small. It's going to be, for instance, 5%. 5 cc per 100 cc, or again, if you assume that the density of the brain tissue is 5 cc per 100 grams. So that's the way the software basically is able to calculate the cerebral blood volume. And it basically applies this principle to those time concentration or those time density curves. So basically, again, coming back to the previous slide, the software is first going to look for the voxel that contains only blood. In order to do that, basically the software is just going to look for the voxel that has the maximal area under the curve. It turns out to be the blue curve here on that particular curve graph. And basically it's going to calculate this area under the curve. And then after that, the software is going to use every single voxel, for instance, the green one again, going to calculate the area under the curve of that particular voxel, and then it's going to divide it by the area under the curve of the blue curve, the curve that has the maximal area under the curve, and that's the way it's going to get to that ratio and to the calculation of the cerebral blood volume. So that has several implications that you have to think of. First, think of, I don't have it here on a slide, but I want to mention it. If the patient head moves, a little bit during the acquisition, well, you may find a voxel in the brain where initially you have brain tissue, but then because then the head of the patient moves, suddenly the skull now ends up in that very same voxel because of the motion of the head of the patient. And of course, the density of the skull is very high because it's bone. And so it's going to create a jump in that time density curve. And sometimes the software may mistake that for the voxel that has the maximal area under the curve. And so that may be one reason where, if the patients move, the software messes up the detection of the venous output function, and that will affect the cerebral blood volume calculation and in turn the calculation of the cerebral blood flow. Other implication of that particular aspect of the software is that the software is not always necessarily going to find an anatomic vein, because really what the software is looking for is the voxel that has the maximal area under the curve, that has the smallest amount of partial volume averaging effect. And so we're thinking of a large vascular structure that's perpendicular to the slices. And so typically, again, in a brain for a normal slice and a normal orientation of the skull, the vascular structure that is large or perpendicular to the slice orientation typically is going to be the superior sagittal sinus. And that's why over time, the software have called that particular voxel the superior sagittal sinus, or the venous output function. But again, it doesn't always necessarily need to be the superior sagittal sinus or even a vein. Here you have an example. You can see that the slices were obtained relatively low because we are going through the orbit, probably something you don't want to do, but that was done for this particular patient. And so you could use the superior sagittal sinus because it's a large vascular structure perpendicular to the slides. But in that particular patient, if you use the straight sinus, you get exactly the same results. And kind of interestingly, if you use the internal carotid artery, which in this patient, because the slices were low, is also a large vascular structure perpendicular to the slices, you can see that you get exactly the same CBV map. So here it's a case where actually the software may be wrong, may pick an artery, you still get the good result that you expect, because again, the only thing that the software is really interested when it detects the venous output function is to find the voxel that has the maximal area under the curve. A situation where that may be a problem, we discussed the situation where the patient's head is moving, and so the skull may kind of mimic a venous output function, so that's a problem. Now let me show you another situation where it could be a problem. If you look at this sagittal scan, and you can see that there are some slices that are obtained in the lower portion of the brain, and you have some slices that are obtained in the higher portion of the brain. Well, in the lower portion of the brain, the suprasagittal sinus is perpendicular to the slices, and as a result, there is not a lot of partial volume averaging effect, and so you can get the maximal area under the curve. It's going to work great. But now if you turn to the slices that are located higher up in the brain, you can see that now the suprasagittal sinus has an angulation compared to the slices. And as a result, there may be some partial volume averaging effect. And so the area under the curve may not be as maximal as it should be. And so here's the end result. So if you use the venous output function for the first two slices, you can see that you get a large maximal area under the curve, which is the denominator. And so when you divide the area under the curve in each voxel by that very large maximal area under the curve, that large denominator, you get normal but lower CBV values, like demonstrated on those two slices on the left. You can see that the CBV range is around 4 to 6 to 8 cc per 100 gram. But now if the software uses the two slices on the right and picks the superior sagittal sinus as the venous output function, the area of under the curve in that voxel is not as high, as maximal as it should be. The denominator is not going to be as large as it should be. And so now when you divide the area under the curve in all the parenchymal voxel by that denominator that's not as large as it should be, you get a ratio that's higher than expected. And that's why you can see that here the CBV values are a lot higher than the range of 10 to 18 cc per 100 gram, which is of course an overestimation. You can fix that problem by using the same venous output function for all 4 slices, and you can see that now you get much more realistic CBV values, again in the range of 4 to 8 cc per 100 gram. So again, something to be aware of, because we use then the CBV information to calculate the CBF, and we use the CBV and the CBF to delineate the infarct, the ischemic core. And so that has some very important implications. So again, the softwares are very good. In 99% of the cases, those automated software do really a very fine job at identifying the venous output function properly. But there may be one patient out of 100 where the software is wrong. And then you need to be able to recognize what's going on so that you can adjust your interpretation. And here, the key is to see if the problem is mostly with the CBV and in turn with the CBF. Something may have gone wrong with the selection of the venous output function. And you may have to reprocess this data set and select manually the venous output function to better match with the characteristics that it should have. All right, now let's turn to the artery. So the artery, the situation is different because this time, again, as I explained to you earlier, the artery is used to calculate the temporal information, so the Tmax, the MTT, and also in turn then the CBF combining the CBV and the temporal information. So for the artery, you need an anatomical artery. And the question often that happens is which artery should you pick? And that depends a little bit on the patient's condition, and also often you have to review your CTA, and that's something that I'll mention again later. Typically, when you do perfusion imaging, you should interpret the perfusion imaging in a vacuum. You should look at your non-contrast head CT. You should look at your CTA because it's important to, again, combine the information of all those modalities to be able to make sense of the results that you get with the perfusion imaging. The difficulty in the setting of the selection of the artery is you have really a range of conditions that go from an acute ischemic condition on the one hand, where you just have a clot that acutely obstructs an artery. And then you have at the completely other end of the spectrum, you have chronic vascular conditions. And the difference between those conditions is basically when you have a chronic vascular conditions, typically the patient is going to have the time to develop a lot of collateral circulation. And as a result, because of those collaterals, there may be ways that the blood and the contrast bolus we inject may get to a certain vascular territory in a delayed manner, but in a normal manner. I'm going to illustrate that with a couple of examples because it's easier that way. So when you have just the acute condition, sure, the patient is going to activate some collaterals, but it's not to the same degree. And as a result, so when you have just a plain acute stroke in a otherwise healthy patient, the selection of the artery doesn't make a lot of difference. And you can do that, when you play with your software package the next time, you can pick different arteries and you see if it's really just a pure acute infarct, whichever artery you pick is not going to have a lot of impact on the results. So typically we pick the anterior cerebral artery because it's easy that way. When now you're dealing with a chronic condition, things are more complicated. And so let me show you a couple of examples. So the first example I'm going to show you is this patient who has a chronic stenosis. So the patient is not having an acute stroke. The patient is not having any kind of acute symptoms. The patient just happened to have a chronic stenosis, an almost complete occlusion of, and because here we're looking from the top, it's the right internal carotid artery. So let's take now the patient is getting a perfusion CT, and then we play with the software. And so on the left side, we process the exact same data set using the anterior cerebral artery. And as you can see, again, because the patient has this right internal carotid artery occlusion, you can see that when I pick the ACA, the anterior cerebral artery, well, the timing of the time density curve in the ACA does not reflect the occlusion of the right internal carotid artery. And so as a result, in the right MCA territory, in the right ACA territory, it's okay because the ACOM and the other, the contralateral, the left ICA helps. But on the right side, in the right MCA territory, the blood is going to get there. Again, the patient is not having an acute stroke. The patient is not having any symptoms. So the blood is going to get there. The contrast is going to get there, but with a delay. And so your time density curve is going to be delayed compared to the one that you measure in the ACA. And so the plain software, and I'm going to come and talk in a minute about refinements, but the plain software basically is going to be fooled by that delay. And it's going to, if you again just pick the ACA as your arterial input function, the software is going to be mistaken. It's going to detect a delayed mean transit time, or Tmax, in that particular right MCA territory. The CBV is going to be normal because, again, the patient is not having a stroke. The CBV is calculated using the venous output function, so it's not going to be affected by that occlusion of the right internal carotid artery. And the CBF is going to be affected because the CBF is calculated as the CBV divided by the MTT. So if the MTT is elevated, the CBF is going to go down. And again, so this tells you something about the patient. This tells you that there is some delay in the right MCA territory. You can see that at this point it's relatively well compensated, and that's why the patient is not having any symptoms. But if you look at those maps very quickly, you could be fooled in thinking that the patient has a right MCA stroke, which is not the case. So how do you fix that problem? Well, the softwares nowadays are very elaborate. Sometimes they can select multiple arterial input functions. Sometimes also they have a process called delay correction where they can correct for that particular delay. And if you apply those principles, basically you can see that now that you have corrected for the delay, it's the exact same perfusion data set, the exact same data set in the same patient who is not having any symptoms, who is not having a stroke. You can see now that the mean transit time is perfectly symmetrical. The CBV is completely unchanged because, again, the delay correction, the selection of the arterial input function affluence the temporal parameters, whereas the CBV is calculated using the venous output function. And you can see that the CBF, which is again calculated as the CBV divided by the MTT, is back to normal. And that reflects better the current situation, the compensated situation of the patient who is not having any symptoms. So again, the arterial selection has an influence on the MTT and the CBF, whereas again, it doesn't influence the CBV, which is calculated based on the venous output function. Here's this other example, which is a very nice example. So here, you have this patient who has this giant aneurysm involving his, and I think that the images are flipped here, and I apologize for that. It's the left ICA. And you see, basically, again, same thing that I described earlier. Basically, so in the left MCA territory and also in the left ACA territory, in that image on the left, if you just use the ACA as your arterial input function, there's a kind of a washing machine, a swirling effect in the aneurysm. So the contrast gets there, but then it stagnates, it whirls a little bit in that giant aneurysm, like in a washing machine, before finally going higher up into the left MCA territory. And you can see that as a result, there is a delay in the time parameter and a decrease in the CBF, an apparent decrease in the CBF in the left ACA and MCA territory. If you use a delay correction process, or if you use a multiple arterial input function, you can see that again, there's this delay. But once you correct for the delay, the dynamic of the contrast, once the contrast finally gets out of the washing machine and makes it to the vascular territories, the dynamic of the contrast in the vascular territories, in the capillaries is normal. And as a result, the CBF is normal. And in that particular patient, we had obtained xenon CT, stable xenon CT, which is a diffusible tracer. It's not affected by arterial occlusions. And as a result, it's a good gold standard. And you can see that indeed the CBF map that you get when you use the delay correction matches what you get with the stable xenon CT, and also matches the patient's symptoms, which are none. The patient is not having acute ischemia. The patient is not having acute neurological findings. So something that is important to remember again in the selection of the artery and the vein. Now I wanted to remind you about the interpretation of those maps. So again, typically you are going to look at them in combination. So typically the map that I look at the first is the Tmax or the MTT, because it's the most sensitive one. When something happens in the brain, you know, in 99% of the cases, you're going to see it on the MTT or the Tmax. And basically, typically, again, with a couple of exceptions, the Tmax and the MTT are going to increase, showing that it takes more time for the contrast and the blood to get in a specific region of the brain. Now, in an initial phase, the reaction of the brain is going to try to compensate for that delay. So the brain is going to try to activate autoregulation, vasodilate local vessel, recruit a couple of collaterals that would be available, and the CBV is going to go up. And if those autoregulations mechanism work well, if the CBV increases in the same proportion as the MTT or the Tmax, well, the CBF is going to be maintained, because again, the CBF is nothing but the CBV divided by the MTT. So if both the numerator and the denominator increase in the same proportion, the CBF is going to be maintained. That's typically what you see in a patient who has a TIA. So in a patient who has a TIA, you see the mean transit time increased in the right MCA territory here. Perhaps I can convince you that the CBV is a little bit increased also if you look at the last row, and as a result, the CBF is maintained. When you see a pattern like that, of course, you know, there are several things that you can do. Your first reflex should really to look at the CTA, because if it's truly a TIA, you are typically not going to see an occlusion on the CTA. So that's the first thing. The second thing that you want to do is, of course, to make sure that you are dealing with a vascular territory, because sometimes you can have a similar pattern, but in different conditions, in patients with migraines, in patients who had a seizure, and now are in the post-seizure, the post-ictal phase. But then typically, the distribution of the MTT or Tmax abnormality will not match a vascular territory. So that will be your clue that you are dealing perhaps with something else. And of course, the most important thing is to discuss with your clinicians, because they'll tell you if the symptoms are getting better. You may raise with them the possibility of a migraine, of a seizure. So again, you don't interpret perfusion imaging in a vacuum. You always have to also interpret it in combination with the other imaging modalities that you have, including your CTAs, and always very important also to discuss with the clinicians to really understand the clinical manifestations that the patient is experiencing. Also, by the way, you know, in a TIA, you want to look not only at the intracranial arteries, but also at the cervical arteries. Very, very important. Now, the brain, once the clot remains for more than a certain period of time and doesn't go away like in a TIA, typically those autoregulation mechanisms that the brain is activating are going to be a little bit overwhelmed, and the CBF is going to start going down. Initially, the CBV is still up, but then once the tissue is dead, when you are dealing with the ischemic core, then the CBV is going to go down. And that's typically the way you can differentiate the ischemic core from the penumbra on perfusion imaging, is by, again, looking at this mismatch between the temporal parameter and the CBV or the CBF parameters. And there are different definitions that are out there. And so that's the principle that is being used. So I see that we have reached the limit of the presentation. I want to make sure we have time for questions and a discussion. So I'm going to pause here.
So thank you very much for this exciting talk. I think this is really a great presentation that we have had tonight. So I would like to thank you for that. And if you still have some time, we have a couple of questions from the audience and from the chat also. The first one is 4D CTP could be better compared to classic acquisition. What do you think about 4D CTP?
So I think that definitely, 4D. So I think, I guess my question will be a little bit, what your question is. So let me answer in a couple of different ways. So the first thing that I would like to say is, you're often, constrained by the type of CT scanner that you have. And so what you can do depends on the scanner that you have. And so if you indeed have a scanner that has a very large coverage, one thing that you can do is you can obtain multiple rotation, and you can acquire the perfusion CT at the same time as the CT angiogram, and you can get kind of a dynamic CT angiogram at the same time that you get the perfusion CT. And I'm assuming that that's what you mean by 4D perfusion CT, CTA.
That's exactly what I think. Yeah.
And definitely it's a big advantage because you get a lot more information than by doing successive slabs. You can cover the whole brain, and as a result, you are sure you are not going to miss the infarct if it's not in a large territory infarct in the typical location. So there are definitely advantages to that. Now, again, not everybody has one of those volumetric CT scanners, and sometimes you have a scanner that has a smaller coverage. In that case, you have different options. The first thing is that there are different toggling table techniques that have been developed. They have different names depending on the manufacturers. They are called the shuttle mode, the jogging mode, the spiral mode. All of those are also acceptable provided that the temporal resolution is adequate. What also we sometimes do is, if you don't use those techniques, you can just use two boluses of contrast, and you do a first acquisition at a certain level and then a second acquisition at a higher level. But of course, if you have a volumetric CT scanner and you can do a 4D perfusion CT/CTA, you don't need to recourse to those alternative techniques.
Yes, absolutely. It's just
Okay,
that my thing was muted, but don't worry. So
okay, good.
we have another question which says, regarding the table of responses you showed at the end, how, if at all, does acute therapy affect those situations?
Yes, so that's a great question. So I think, so a couple of things. I think that the first thing I would like to say is that's one of the main difference between MRI and CT. So in MRI, we have diffusion weighted imaging, and you can look really at the viability of the tissue, and then you use the diffusion perfusion mismatch to look at the penumbra, the tissue at risk. It works great. There are a couple of exceptions with DWI reversal, but really 99.9% of the cases, it works great. When we look at perfusion CT imaging, we do not have diffusion weighted images. So we have to extract the viability information from the perfusion information. And so the assumption that we make is that the cerebral blood volume, when it's low, indicates that the tissue is going to die. And again, that's a rule that works well. And, I mentioned 99% for DWI, so I'm going to use 90% for the perfusion CT imaging. When the CBF or the CBV are decreased below a certain threshold, it usually indicates in 90 to 95% that you are dealing with the ischemic core. Now, the exception, the remaining 4-5% are for patients where the tissue get revascularized extremely quickly. And so there have been instances demonstrated of reversal of that very low CBF or CBV in those patients who undergo mechanical thrombectomy extremely early. So that's something perhaps to keep in mind. The reversal, it's kind of a little bit like the DWR reversal. It's never complete, but it can happen. And so that's something that you just need to keep in mind when you make those treatment decisions. One thing that is very important to get the appropriate CBV values is to make sure that you don't truncate the cerebral blood, the venous output function curve. Because if you truncate it, then it may lead to miscalculation of the CBV. And so that's why typically the protocols are established such as you cover and you don't truncate that venous output function curve in order to calculate your CBV volumes correctly. Otherwise, it could accentuate that issue of the reversal. So that's what I had to say on that particular topic.
Yeah, that's clear. Thank you. So another question, most perfusion post-processing softwares for stroke are based on threshold. They all use different algorithms, so obviously the thresholds are different. How do the clinicians deal with these differences? Are they aware that the threshold from one vendor may not apply to another?
Yeah, so I think that's where the role of the radiologist is really important, because we are the expert, and I think we understand that better than our clinical colleagues. And I think what you see is completely correct. I think, when you take the same patient, the patient gets the same perfusion CT, and you take the same perfusion CT data set and you feed it to different software, you get slightly different results. Exactly. And then, of course, the different software apply different threshold. And then I believe that the end result, the ischemic core and the penumbra, are very comparable from software to software, because, again, each software has been optimized, and the thresholds used by each individual software are optimized for that particular software, so that the final result is congruent and consistent amongst platforms. What you don't want to do is to read in an article about software A that uses those threshold X and Y. And then at your institution, you are using software B. And now you try to apply blindly those threshold X and Y that work really well for software A in that article, but that are not going to work for software B that you are using at your institution, and that could give you inaccurate information in your decision-making process. And so that's something, in my experience, that often our clinical colleague may not understand, because they go to a conference or they read an article, they are all excited about something, and then they want to use that exact method, and they may not understand that while you could use the same concept, but then adjust it and optimize it for the software you use, you cannot just blindly use thresholds and cutoff values reported for different software. So I think that's very important. But again, I think that's where radiologists are expert at your institution. And again, using the expertise and the experience you have with the software you are using, what are the optimal parameters, the optimal cutoff values, and you can provide very reliable information for the clinician to make their clinical decisions. So very important point that you are bringing up.
I fully agree with you, and I thank you very much for your answer. One last question, and then we will close this webinar, if you don't mind. Right. So the last question is, do you see an impact with dose reduction and artificial intelligence?
Yes, so definitely. I think that, we always want to try to reduce the radiation dose that we give to our patients. I think it's particularly true for perfusion CT because we scan the patient repeatedly in the same location. Now a decade ago, more than a decade ago, when perfusion CT was introduced, there was an incident at one of the sites in Southern California, and basically the patients underwent the wrong protocol. and they underwent that wrong protocol multiple times. And so they developed that particular hairstyle with losing their hair in that circular way around their head. And that's, of course, something we want to avoid and not see again. I think the things you can do to minimize the radiations first. So when you do CT perfusion or perfusion CT, you should use 70 or 80 kilovolt peak, because that's what is optimal to capture the information from the contrast you're injecting. And also by decreasing the KVP, you decrease the radiation dose by the square of that decrease. So it's very important. Because again, all those software platforms like the Olea software have a lot of smoothing algorithm. You can also use low MAS, so typically around 100 to 150 MAS. The thing you can do additionally, so some of those techniques like the toggling technique that we discussed earlier allow to increase the coverage while maintaining the same amount of radiation. So that can be beneficial too. And then, of course, nowadays we have multiple other approaches that have been used, including AI, to try to reduce either the amount of contrast that you are administering or to reduce the amount of radiation dose. The only thing I would like to caution you is, again, you have to be a little bit careful when you try to reduce the dose too much, because you may decrease your sensitivity to ischemia. For the arterial input function and the venous output function, because the signal is so strong, of course, you can reduce the dose quite a lot and still capture your artery and your vein. And so you can still calculate normal CBF, CBV, MTT value, but in an ischemic territory where you are trying to distinguish between preserve versus altered autoregulation, the signal is much less. And so you need to keep that signal. And so, again, so it's good to use radiation dose reduction techniques, but you have to do it like everything in life in moderation. And the last thing I wanted to say was that, of course, there's also a CTA, the patient may get an angio, the patient may come back for follow-ups. It's particularly true for patients suspected of vasospasm. And that should also be the reflex of the radiologist. When you get your third request of CT perfusion, CTA in a patient, perhaps it's time to call the clinician and say, do you really need it? Do we really need to do all that again? Patient had it already twice. And of course, you have to factor the age of the patient. It may be less important in an 80 or 90-year-old patient, but in a young patient, I think that's, again, the role of the radiologist to be a good steward of the use of imaging.
I know I said it would be the last question, but I have a lot of questions flooding. So
okay.
Do you agree that you answer one last question? Really?
Sure, of course.
So how about fully automatic softwares in case of atypical patients?
Yeah, well, again, the automated software, they serve a purpose because they really help speed the workflow. They help ensure that the patient get their results immediately. It allows to make sure that we don't have any delay in those treatment decisions that are critical because time is brain. Again, the automated software work great in 95 to 99% of the cases. There are still a couple of cases where they are not going to, they are going to do what they are supposed to do, but because the patient is moving, because of the shape of the head of the patient, because of the orientation of the head of the patient in the scanner, the automated process is going to do what it's supposed to do, but fail in terms of what we're expecting from it. And I think that's where, again, that's why I see the role of the radiologist. If those software were 100% perfect, well, what would be our job? We wouldn't have a job. But, the good thing for us is they are not 100% perfect. That's why I wanted to present those things today. We need to understand how those automated software work, because for those atypical patients, for the one patient out of 100 where things don't go according to plan, well, then it's important that the radiologist then is able to figure out what's going on, to explain what's going on. And, again, I think our role is also very important, so I think that's sometimes a pitfall that I see in my practice, when you have a software that provides number, and it's not just perfusion, it's all types of number. Our clinicians tend to interpret those numbers literally, and there are some nuances, and we understand as radiologists those nuances because we use the different modalities, we use also the clinical information, and I think it's really our job to help with those atypical cases, and that's really where our value lies.
I cannot agree more with your statement. Okay, so I said that this would be the last question, so it's really the last question, and on that I would like to thank you very much first for this excellent talk that has been recorded, so you can probably access it afterwards through the Olea Academy if you need it. And not only for the talk, but also for the time that Professor Wintermark has taken to answer these questions. I think this is really a great added value. So it was a great pleasure for us being with you today. So I would like to really, on behalf of Olea, all to Olea Medical, to thank you very much for your time and your commitment to this webinar.
Thank you, Frank, and I appreciate again. And I see also that in the comment, the next webinar will be by Dr. Philippe Grenier on artificial intelligence, a new companion for the chest radiologist. And Dr. Grenier is an amazing speaker, so I'm sure that we'll all enjoy that presentation. He's just an amazing speaker.
So actually you are doing my job. That's great. That's great.
Okay. Sorry.
So thanks a lot for that. I don't have anything to add then. And on this, I will be closing this webinar. And I thank you again very much for all the time you have taken and the answers that you have provided. Thanks a lot. Have a nice day.
Thank you. Have a great day. Have a great evening, everybody.
Cheers. Bye.